Welcome and thank you for joining us for today's session of frequently asked questions on understanding your labs. I'm Mary DeRome, Senior Director of Medical Communications and Education at the Multiple Myeloma Research Foundation. Today, I'm joined by Dr. Hans Lee and nurse practitioner Becca Liu from MD Anderson Cancer Center in Houston, Texas, and Lauren Eves, who is a myeloma patient living in Houston, Texas. Patients and caregivers have a lot of questions about all of the lab tests that are used in the diagnosis and management of multiple myeloma. So let's take a stab at answering some of these questions with our panel today. So myeloma patients will be familiar with having bone marrow biopsies, but may not be familiar with what doctors can learn from them. So my first question is to you, Dr. Lee. Among the various cytogenetic and genomic analyses that are done on a patient's myeloma DNA, for example, fluorescence in situ hybridization or FISH, karyotyping, and genomic sequencing, what is it important for patients to know, and how do they put the results from this testing into context?
Yeah, thanks so much, Mary, for the invitation to join on this chat. And I thank all the patients for joining live on this live stream as well. And you bring up some really, really important questions about why is a bone marrow important at baseline to perform, besides just showing that there's myeloma cells on the bone marrow biopsy. And so basically, what's really, really important for the bone marrow biopsy, in addition to showing myeloma cells, is to perform certain genetic testing known as FISH, as you referred to earlier. And essentially, what the FISH testing does is to look for certain common genetic abnormalities that might be present in patients' myeloma cells. And this actually can be important for informing prognosis, but also in some cases help dictate which treatment approaches we may take. And so to get a little bit more specific, so there's certain chromosome abnormalities that we would consider what we call high risk. And so high risk myeloma basically refers to myeloma that actually responds fairly well to therapy, but has a higher chance of coming back earlier, having an earlier recurrence. And so essentially it's a more aggressive type of myeloma. And so there are certain genetic abnormalities such as something called deletion of 17p, which is loss of part of chromosome number 17 on your myeloma cells. Sometimes there's extra material on chromosome number 1. Sometimes there are certain what we call translocations, or saying exchange of material between different chromosomes. So sometimes between chromosome number 4 and 14, so there's translocation 414 and translocation 1416. So these are considered what we call more aggressive or high risk myeloma markers. And so essentially that would help inform, in one hand, prognosis, but in other hand, we may also approach treatment a little bit more aggressively in such patients, maybe do a more aggressive maintenance regimen. The other thing that's really important to establish in the bone marrow is also there's certain mutations that can also inform which treatments might actually work better. And so there's actually a drug called venetoclax. It's actually an oral pill. And we've actually learned over the last several years that there are certain translocation 1114 specifically, that actually predict response to this oral pill. So it's nice to know sort of at baseline up front whether you might be a candidate for some additional therapies such as venetoclax later on. It's not something we'll use necessarily in the beginning, but later on it's good to know.
Mm-hmm. So, Lauren, since your myeloma diagnosis, when did you learn that you had a 1Q amplification, and how did you come to understand what that means?
So yeah, I had the FISH done at diagnosis as part of my bone marrow labs, and my initial diagnosis was done by a GP, and he didn't really have the specialist info to provide a lot of explanation.
Mm-hmm.
I just read the lab report that came to me, and it came with the notification that there was a 1Q amp, and a note that said it's an indicator of poor progress, or poor prognosis. Sorry, and that of course piqued my interest, and so it was a lot of self-education. I got on the internet and started digging, and I'll use this opportunity to plug MMRF and HealthTree for the tremendous amount of resources that are available.
Mm-hmm.
So much that I've done has been self-taught. The nurse navigators, the peer program, like there's so much. It's a remarkable amount of time and energy that the community puts into these knowledge transfers. So if you're like me and you didn't have that immediate access to a myeloma specialist, there's a tremendous amount of information out there. When I had the meaningful conversations about the 1Q amp, there were 2 decision points, and one was for transplant decision, which I was dead set against and ultimately ended up doing very reluctantly. But that's when the 1Q amp high risk discussion came in. And then for maintenance as well, and determining what kind of therapy would be the best fit for the high risk marker.
Yeah, makes perfect sense. So, I mean, it's becoming more and more apparent as more research is done that there are risk adapted therapies that can be successfully used for patients who are high risk, which is actually really great. About 25% of myeloma patients fall into that high risk category. So, it's important to really make sure that those patients are diagnosed as high risk as soon as possible. When they're diagnosed with myeloma, so that this risk-adapted therapy can be brought into play with their care plans. So, Dr. Lee, which, if any, of the cytogenetic or genomic results can change over time, and how often does this DNA testing have to be repeated?
Yeah, so as you mentioned, Mary, it's critical to get it at baseline. So I just put the plug in that, patients being newly diagnosed with myeloma, if you haven't had the FISH testing at baseline, make sure that your doctor orders it as part of the bone marrow biopsy. And certainly that would be a reason for me to repeat the bone marrow at baseline if it wasn't done, because it's really, really critically important. But you make a great point, Mary, that genetics can change over time. The myeloma cells can adapt and evolve depending on different treatments that they receive, and they can make them more resistant to certain treatments as well. And the sort of scientific or medical word we use is clonal evolution. So these cells can evolve. And so typically, in terms of when I repeat a bone marrow, so initially I do repeat a little bit more frequently just to assess response. So it's just essentially after initial, what we call induction therapy, which is the 3 to 4 drug regimen that you'll probably receive at initial diagnosis. I will probably repeat the bone marrow after 4 to 6 cycles before potentially going forward with the transplant. And then also after the transplant itself to assess response as well. But beyond that, other critical time points, I think it's important to repeat a bone marrow is at the time of every relapse potentially, because that sort of may inform further changes in the genetics that might explain if the myeloma is evolved, and there can be changes. So broadly speaking, there are sort of 2 types of genetic changes. So we call these, on the one hand, sort of primary genetic events. So these are actually what kind of cause the myeloma cells to convert from a normal plasma cell to a myeloma cell at baseline. And so these are commonly translocations involving chromosome number 14, essentially exchanges of material between chromosome 14 and other chromosomes. So, for instance, a patient had translocation we call 1114 at baseline. We wouldn't expect that to show up later on because that's what we call a primary genetic event. But then there's other events such as what I referred to earlier, deletion of 17p or changes in chromosome number 1 that can basically make the myeloma more aggressive. And those changes can occur over time. And it is nice to know if those changes are present, because that can also inform prognosis, how the myeloma might behave, how it might respond to therapy with every subsequent potential relapse.
Okay, so Becca, what are some issues that patients may face when they're having a bone marrow biopsy? Is it possible that you might not receive sufficient information from the testing results, or there might be a lack of appropriate cells to test after the biopsy is done?
Yeah, thanks so much, Mary. So we all know bone marrows are not the most comfortable procedures. The patients would need to lie on their stomach, which is prone, while the procedurist obtains the samples with an aspiration needle from one side of the patient's hip. Because this procedure can cause bleeding and many of our patients have low platelet counts at baseline, it's very important that the patients consult with their provider on the time frame to hold any anticoagulants if they are on any. So first, the area of the hip is numb with lidocaine before the procedurist enters in with the aspiration needle to draw that liquid sample. Sometimes a dry tap can occur. And what this means is the procedurist has inserted the needle and fail to obtain enough of that sample of the aspirate.
Mhm.
This can interfere with diagnostic evaluation, and this can happen in myeloma, which is a pathologic condition, especially if the marrow is very packed with malignant cells. This may necessitate redirecting that needle, so the procedurist may need to go in at a different angle. They may need to withdraw the needle completely and reinsert it, which is obviously not the most comfortable thing, right? But
Yeah.
after redirection, the procedurist may still be unable to aspirate enough good quality sample. They do their best, but the sample does not yield sufficient cells. This is usually indicated in the pathology report, and so the clinician would need to interpret accordingly.
Right. Right. So it's interesting because you do hear different reactions to bone marrow biopsies, bone marrow aspirations from different patients. We did one of these live streams last week, and the gentleman who was a patient who was on that call with us described it. To him, it was kind of like nothing. It was like getting stung by a bee. That's how he described it. So I guess it's different for everybody, right?
Yeah, for sure.
So Dr. Lee, what about patients with precursor conditions? Should someone with smoldering myeloma or MGUS have a bone marrow biopsy?
Yeah, another great question. So I would say that any patient with suspected smoldering myeloma should get a bone marrow biopsy because we want to actually quantify the percentage of plasma cells in the bone marrow. As people may know, there's criteria that define smoldering myeloma versus myeloma. So 10 to 60% plasma cells in the bone marrow would be in the smoldering myeloma range, whereas greater than 60% would be in the myeloma range and less than 10% would be in the MGUS range. So it'd be good for informing prognosis, follow-up intervals, and things like that to get that concrete diagnosis. Now, MGUS is a little bit more probably of a gray area, to be quite honest. And so, MGUS for the audience is the earliest precursor state to myeloma. So these are patients with an M protein of less than 3 grams per deciliter and bone marrow plasma cells less than 10% in the bone marrow in the absence of any myeloma symptoms, bone disease, kidney problems, calcium issues, and anemia. And, there's been some studies looking at this actually. So, if a patient, for instance, has an M protein of less than 1.5 with a normal free light chain ratio and an IgG type M protein, the risk of actually having more than 10% plasma cells in the bone marrow is actually fairly low, about 5% or so. And if the M protein is less than 0.5, it's actually even lower. It's less than 1%. So, I'd probably say I'm probably err on the side of being a little bit more conservative in my own personal practice. And so I would say, if the M protein is more than 0.5, I'll probably still get a bone marrow because I'm probably, quiz the patient on symptoms and probably hypervigilant. If they have a little bit of bone pain, I really want to make sure that we're not missing anything related to the myeloma. But I think in patients with M proteins of less than 0.5, normal free light chain ratio, having no symptoms whatsoever, I may omit the bone marrow in that case because the yield would be fairly low, and the probability of actually having actually more than 10% bone marrow plasma will actually be fairly low. And so in such cases, I may omit it. And it's important just to talk to your doctor about that for the people in the audience because every case is individualized, and so you can't really put everyone in one box versus another box. So one size doesn't fit all. But just important to talk to your doctor about the pros and cons about doing a bone marrow, for instance, in the MGUS state.
Right. So, and if a person is smoldering, then having the bone marrow done, and you can actually, find myeloma cells there, and then actually do some of the DNA analysis, which might then determine that a person is actually high risk smoldering, which would also mean that they might be then eligible for certain treatments that are available on clinical trials for high risk smoldering patients, which is another thing that would be useful.
Yeah, absolutely, Mary. That's a great point you make up. And sort of the same high-risk genetic markers in myeloma often really apply to smoldering myeloma as well, with a greater risk for progression. And so things like deletion 17p, invariably is a high-risk marker for either smoldering myeloma or myeloma. And a great point you make to also test the FISH testing that we talked about earlier.
Right. So we'll talk a little bit now about minimal residual disease, or MRD. And this is being used more and more to assess treatment response in clinical trials. So Dr. Lee, are there certain mutations or abnormalities that make it harder to achieve minimal residual disease negativity? And I know that you were talking earlier about how important it is to get that bone marrow sample when patients are diagnosed. And that's really an important part of MRD determination, especially if you're using next generation sequencing techniques, right?
Yeah, so MRD testing is basically a way we can look really, really deep into the bone marrow to look for those residual myeloma cells. And sort of the minimum standard is to look for one abnormal myeloma cell out of 100,000 normal bone marrow cells. And so that's sort of what we call 10 to the -5 sensitivity. And so, interestingly, and I think this is probably best studied in by Dr. Costa at UAB. He actually recently published a study called the MASTER study and really looked at serially MRD testing, MRD results in patients that received really state-of-the-art induction therapy, transplant, followed by additional treatment cycles. And he really looked at sort of MRD rates in high risk and standard risk patients. And I think, interestingly, some of the take-home messages from that study did show really comparable, actually, MRD negative rates in standard risk myeloma patients and high risk myeloma patients, actually. But what was different was what we call sustained MRD negativity. I think this really correlates to what I see in my own practice as well. And so, patients with high risk myeloma can actually attain MRD negative at a single time point. But I also am a little bit cautious by reading too much into that. And so it's because what makes high risk difficult is that the myeloma can relapse, recur fairly quickly. And this is consistent with what Dr. Acosta saw in his study, was that the rates of what we call sustained MRD negativity, so MRD time points, two negative time points 12 months apart, were actually far less in patients with 2 or more high-risk cytogenic abnormalities versus 0 or 1. And so I think, again, attaining sustained MRD negativity is harder in high-risk multiple myeloma. I think what was also interesting about that study was that in patients with 0 or 1 high-risk cytogenic abnormality, actually the outcomes are fairly similar. And I think what this shows is this is really a testament to where myeloma therapy has come. Whereas, historically speaking, 15 years ago, having one high-risk cytogenic abnormality would be obviously an adverse prognostic marker. But because we have new treatments and novel therapies, I think some of these treatments are actually turning the tide against some of those patients that just have a single high-risk abnormality.
Yeah. So there's been so much progress made, especially recently. And if anybody listening is interested in hearing more about MRD, actually from Dr. Costa, we did do one of these sessions on Facebook Live with him last week around MRD. So it was Dr. Costa and also his nurse practitioner and his patient, the one who thought that the bone marrow biopsy was like a bee sting. So that was a great session. So we have that on our website, and anybody who wants to can just sort of listen to that recording. So Lauren, let's talk about your MRD testing. So how did you educate yourself about MRD, and what would you tell other myeloma patients about MRD based on your experience?
So although I had a bone marrow done at diagnosis, my MRD test wasn't actually run until many months later. And I educated myself about MRD in a similar way with other things before I had a specialist, just doing a lot of internet research. And by the time I really came to know about MRD and pay attention to it, I was under a specialist care. And, of course, then I said, I need to have this MRD testing. What I would tell people is if you didn't get MRD at baseline for the next generation sequencing, don't panic. The 10 to the -5 is still a really good indicator of residual disease. I'm kind of obsessed with my MRD. I think myeloma patients probably are. You want to know that clone is going away. You just want it gone, right? And the MRD is the best indicator of that. So I started chasing my bone marrow slides, which were in South Africa, and I was able to get from Adaptive. They had a really great little one-pager of this is exactly what we need. I contacted the lab and was able to get the slides shipped from Johannesburg to Seattle. So, if you did get that bone marrow biopsy done, there's a chance that the material is still there and they can still, analyze it for MRD if it wasn't done initially. I would also say, keep an eye on the science. What I was reading about MRD a year ago and what I'm reading now, it's just there's so much more available. It's really
Absolutely.
an emerging field, and it's clearly an important data point in our myeloma labs. How best to use the information and is going to evolve. Um, I'm one of those people who gets multiple opinions, and when I had my opinions and asked about MRD, I got 3 different answers,
Mhm.
which be careful what you ask for in that sense.
Mhm.
So I think it's pretty amazing what's happening with it, and we'll see over time what it means for us.
Yeah. So, I mean, it's a little dicey because there really aren't a lot of guidelines yet published on what to do with the information, but certainly it's a good way to tell how well patients have responded to, especially their induction therapy, either whether they're having a transplant or not. So it's great for that. And there's a lot of research being done on MRD in many clinical trials, including the master trial, which Dr. Lee was talking about. So I think that, the more data we collect on patients, using MRD testing, the easier it's going to be to then formulate these guidelines. And I think it's also really interesting that when we first started talking about MRD, it was always testing that was, one cell in 10,000 or one cell in 100,000. But now it's moved on to one cell in a million, or even one cell in 10 million, because they're now talking about 10 to the minus 7th. So it's just becoming more and more, the testing is becoming more sensitive all the time, which is great news for patients. So, okay, so let's move on a little bit now to blood tests. These are really a staple of multiple myeloma management, and there's a lot that doctors can learn from them. So, Dr. Lee, what do patients need to know about serum free light chains? What are they? How do they impact treatment? And how do you interpret changes in those levels?
Yeah, so broadly speaking, myeloma cells secrete antibodies or the paraprotein, such a monoclonal protein, and they secrete them into the blood. And this is how we track how patients are responding to therapy. If the levels are lower, we know that we're killing myeloma cells successfully, and the patients are responding to therapy. And so, broadly speaking, these immunoglobulins basically have 2 components. One is called the heavy chain, and one is called the light chain. The heavy chain can consist of most commonly IgG, but sometimes IgA, IgM, or IgD. And the light chain component can either be a kappa or lambda light chain. And sometimes the myeloma cells produce both. Sometimes they produce one or the other. Sometimes, again, they just produce the light chain. And so, in someone without multiple myeloma, you should have an equal number of kappa producing plasma cells and equal number of lambda producing plasma cells. So, what we really look at is the ratio when someone is diagnosed with myeloma.
Mm.
And what we're looking for in a patient, for instance, without myeloma is seeing a normal ratio, or someone that's responding well to therapy and seeing a normal ratio. Essentially, you've extinguished or decrease the amount of the abnormal plasma cell producing either the kappa or lambda light chain. So again, it's the ratio that's most important. And just to kind of give you an example, so for instance, if I had a recent infection, for instance, if I had some inflammation going in my body, both my kappas and lambdas would probably be elevated if I got blood work. And so that's not, of course, a cause to panic necessarily, because the ratio would still be normal, because this is basically just a general increase in the immune system activity. But when we see that skewing in the ratio, then we know that one type of myeloma cell has basically started to grow more uncontrollably. I think it's also, though, important to look at sort of the big picture, because if you can imagine, the ratio is often dictated also by the denominator. So we say capital lambda ratio. So for whatever reason, the lambda is like really low at a single time point, then that could skew the ratio. And so, if the kappa was 20, for instance, and the lambda went from 4 to 2, that would actually double the ratio. So, look at the big picture, because, that's also not a reason to panic that my ratio doubled, based on the decrease in the lambda light chain.
Mhm.
But if I really want to sort of kind of give general sort of guidance, is that it's really, really important to look at trends. So, one thing I try not to do, and I also tell patients as well, is don't really look at a single time point to dictate sort of a decision treatment. Certainly if the ratio went up really, really high from one point to another, that'd be concerning.
Mhm.
But if there's a subtle
Mhm.
change from one time point to another,
Mhm.
really that's not super informative. So, looking at, okay, is this a clear trend up? Then that's a reason for concern. But sometimes it can bounce around, particularly the light chain ratio can bounce around a little bit. And so again, really look at the trends and not necessarily a single time point.
Yeah, that makes sense. So, so Becca, let's talk a little bit about the Comprehensive Metabolic Panel, or CMP, and what in that panel is important for a myeloma patient to know and why.
Yeah, thanks, Mary. So a CMP is going to look at the patient's electrolytes, kidney function, and liver function tests. And we'll use the CMP to assess part of the myeloma defining criteria, or that CRAB criteria. When reviewing the CMP, we want to look at the creatinine, which would tell us if the disease is impairing the kidneys or not. We'd also want to look at the calcium levels to make sure they're normal. Bone is made of calcium, and we know that myeloma causes bone destruction. So when bone is getting broken down, that calcium is being released into the bloodstream. High levels of calcium in the bloodstream can cause many different issues, like neurological issues, cardiovascular issues. It can cause renal failure, kidney failure. So we want to make sure that it's okay, but the calcium level that we see on the CMP is not a true level. So the provider would need to correct this level with albumin. Albumin is a larger protein molecule in our blood that binds with calcium. We have a formula that we use to get that corrected calcium level. If the calcium levels are still high, this would warrant immediate intervention, which may include fluid hydration, calcitonin administration, or correction of that calcium with biphosphonate therapy like Zometa, or any combination of the above three. So yeah.
Okay. So another common test that patients wonder about is the serum protein electrophoresis, or the SPEP. Dr. Lee, what's the meaning of the various components of the SPEP results, and how should patients interpret those changes?
Yeah, so as I mentioned earlier, there's different components of that immunoglobulin, and the heavy chain and the light chain. And essentially, the SPEP measures the amount of the paraprotein M protein that the myeloma cells are producing. And so kind of an overview of what the test actually is. So basically, your blood is essentially inserted onto a gel with an electric current actually run through the gel. And the different proteins in your blood will separate based on their charge. And so different proteins in the blood have different charges. And so in a patient with a multiple myeloma, we'll see a separation actually of the monoclonal protein action, a certain part of the electrophoresis gel, and that part can actually be quantified. And actually that's known as the M spike, or the M protein. And depending on the size of that spike, that actually quantifies, what the number is. And so that's what the SPEP actually measures, is the amount of the paraprotein being produced by the myeloma cells. Now, there's another component called immunofixation. So immunofixation actually is not necessarily the SPEP, but it's a sort of a reflex test, or a test done along with the SPEP. And that actually tells us the isotype, which is basically the type of monoclonal protein that's being produced by the myeloma cells. So as I mentioned, sometimes it could be IgG, sometimes it could be IgA or IgD, sometimes it could be kappa or lambda light chain. So the immunofixation, either in the urine or in the blood or the serum, can tell us the type. So SPEP quantifies the M protein, immunofixation tells us the type.
Mm-hmm. Does that play any role in what therapy the patient might get at some point, or is it just one of these good to know things?
Yeah, it's more of good to know. So it's basically, once you know the isotype, or basically, then you know what to track, basically. And so you know the markers to track, whether that be IgA, IgG, kappa or lambda ratio, et cetera, et cetera. And so essentially getting to that baseline, and then we know what to follow. But really at this point, it doesn't really have any sort of implication on prognosis or what types of drugs we would use, either for a kappa, lambda, light myeloma, or an IgG or IgA myeloma.
What if
one thing I will mention is that IgA type myelomas are a little bit more hard to detect or quantify on the SPEP. And so actually quantitative IgA levels are actually probably more accurate actually in assessing response. in patients with IgA myeloma. So that's one little caveat actually with the SPEP is that patients with IgA myeloma actually you may actually follow the IgA levels as more of an accurate assessment of response.
Mm-hmm. How common is IgM myeloma?
Oh, it's exceedingly rare. It's pretty
That's
rare.
what I thought. You don't really hear people talking about that very much. I mean, the
Yeah.
IgM is so different from the other Igs. Like it's such a much bigger structure. So
I probably have less than 5 in my practice, and this is, I have, probably over 1,000 patients in my own personal practice with myeloma. So it's rare.
mhm.
And I think, oftentimes IgM plasma cell disorders are often a different disease called Waldenstrom's macroglobulinemia. And so
Oh, okay.
actually true IgM myeloma is actually very, very rare.
Ah, gotcha. Okay. Thank you. I'm getting the education right now. That's good. Okay, so Becca, are these results interpreted the same regardless of the myeloma immunoglobulin isotype a patient has, for example, IgG or IgA? And how common is it for a patient to have IgD myeloma? When we did our webinar about Learn Your Labs a few months ago, there was a patient who was writing into our comments that they had IgD myeloma.
Yeah, so the way we review the SPEP can change depending on the immunoglobulin isotype. So as Dr. Lee mentioned, the SPEP quantifies that monoclonal protein or that M protein that's present. And we want that number to decrease, and that gives us an idea of the patient's responding to treatment. However, because sometimes the immunoglobulin structures are different, it can change the way that SPEP is resulted. So for instance, the IgA isotype is a 2-pronged structure, whereas the IgG is a single-pronged structure. And because of this, the SPEP for the IgA may show as different bands on the electrophoresis. So patients may see this on their lab reports, paraprotein 1, paraprotein 1, et cetera. In these circumstances, we look at that immunofixation to ensure that all the bands on the electrophoresis are all IgA isotopes. And if so, you can add them together because it's like adding apples to apples, right, to review the response. However, if the immunofixation says that the bands are different, meaning one band is paraprotein 1 is IgG and paraprotein 2 is IgA, you couldn't add those together. It'd be like comparing apples to oranges. Those responses would need to be made separately. IgD myeloma is quite rare and has a prevalence of less than 2% of all myeloma cases. And because of this, the diagnosis might be delayed due to that lower prevalence. But we would monitor the electrophoresis and treat the patient in the same manner as other isotypes.
Okay, so let's talk a little bit now about imaging. Okay, so Dr. Lee, what's the recommended time for a PET scan to be done? And what can a PET scan tell you?
Yeah, the imaging has really evolved in myeloma over the last 10 years or so. So we used to often do plain films or x-rays of the bones, something called the bone surveys, but that's really fell out of favor because the sensitivity of actually detecting myeloma lesions is actually not very great with x-rays compared to more advanced imaging like PET scans and MRIs. And so it's important to get advanced imaging, either a PET scan or MRI on any smoldering myeloma patient, because we would really want to establish that there is no bone lesions and actually truly the patient has smoldering myeloma, and essentially observation would be generally the standard of care for most patients. On the other hand, so if a patient is newly diagnosed with myeloma, even if they have other sort of, we call it the CRAB criteria, the symptoms of myeloma, if they have anemia or renal or kidney disease, it's still very important to get a baseline PET CT because it's really important to establish what's present or absent at baseline. Because then in the future, if you want to know what's new or not new, if you don't have a good baseline, then you won't know. And so I think a PET scan is really good to look for small changes in the bone, so it can establish where the bone lesions are actually at. But another thing that a PET scan is also helpful for is to look for something called extramedullary disease. So this is basically where the myeloma cells escape from the bone marrow and sometimes form tumors outside the bone marrow, either next to the bone, like we call paramedullary, or basically true osseous extramedullary disease, essentially soft tissue tumors in different organs. And so it's good to establish at baseline if these are present or absent. And I think something that we do see later on in in patients who may have had multiple different treatment options or regimens in the past, the incidence of what we call extramedullary disease does increase. And so then a PET scan can be informative to track these areas that need to shrink, hopefully with different treatments.
Mm-hmm. And isn't now the PET CT sort of seen as part of the MRD family of tests, right? So it's one thing to actually take a bone marrow sample and then count the number of cells, myeloma cells that might be in there. But, you also have to have a PET CT there, right? In addition to really sort of certify somebody as being MRD negative, because they may have just put the needle into a part in the bone where there really isn't any myeloma cells, and they could have extramedullary disease or myeloma cells growing in a different bone in a different place. So
yeah, you bring up a great point, Mary. That's the main limitation with bone marrow MRD tests is that there's a sampling error. If you happen to hit the patch of myeloma cells, you might be MRD positive, or
right.
if you didn't hit that patch, you're MRD negative. So I think it's really important to look at all the tests, blood markers, imaging, bone marrow, and then basically have a sort of collective assessment of what's really going on.
Mm-hmm.
And, for instance, on a clinical trial, if a patient had baseline extramedullary disease, so basically these soft tissue tumors outside the bone marrow, yes, absolutely, we need to do a repeat PET scan to actually confirm response. And if we see a 50% reduction, that'd be a partial response. And actually, we need complete resolution of these soft tissue tumors, via imaging to actually confirm a complete response. And so it's actually a mandatory, actually, in the clinical trial setting.
Mm-hmm. Mm-hmm. Okay, so Becca, some of the patients from our previous webinar on labs were wondering if PET scans can be used to reflect the success or failure of treatment, and if so, how long after therapy are PET scans done? And I think we just heard Dr. Lee talk about the, measuring extramedullary disease with PET scans and how important that is.
Right, yeah. So as Dr. Lee mentioned, if the patient's myeloma manifests as extramedullary disease, then those PET scans are essential in determining the response of treatment, since they are more specific than other imaging modalities. If there is a target lesion at baseline, we will look for that reduction in size to be able to stage response. The current recommendation is to obtain PET CTs after 3 months or after every 3 to 4 cycles of treatment. And this is also because most insurances wouldn't pay for the PET scan to happen sooner. There's also a deficiency of data to support changing treatments based on earlier imaging.
Mm-hmm.
So thereafter, the patients can resume treatment pretty quickly. It would just take the time for the radiologist to report the images and the physician to determine if the treatment is sufficient before making the determination to proceed with the current regimen or to change it.
Okay. So, Dr. Lee, aside from bone marrow biopsies, blood tests, and imaging, what other testing should patients be having? And how much longer will patients have to endure a bone marrow biopsy? So, and what's on the horizon for that testing? I know that people talk a lot about mass spec, which is a blood test and is extremely sensitive, but is not available in that many places yet. So that's kind of on the horizon.
Yeah, I think that it'd be great to do away with the bone marrow biopsies. As Becca mentioned earlier, it's uncomfortable for patients. I think patients online can definitely relate to that. Lauren could probably relate to that as well. And so we could do away. So there are definitely a lot of research going on looking for other peripheral blood-based MRD testing. And so one type of test that's been looked at is cell-free or circulating tumor DNA. So essentially looking at DNA that's shed by the myeloma cells into the blood, and basically trying to see if there's absence or presence of this circulating tumor DNA that's the signature of the myeloma cells.
Right.
And so, I would say by and large, this is probably not ready for prime time in terms of being on par with bone marrow MRD testing. So most studies have shown probably a 1 log decreased sensitivity. So instead of 10 to the -5 sensitivity, probably 10 to the -4 sensitivity with these blood-based markers. But if successful, what it would be nice about these blood-based markers is that it would sort of eliminate that sampling error that we talked about earlier about potentially missing the spot, because the blood is circulating all over your body. So it's basically representative of what's going on in your entire body, not just a single spot in your hip. Another sort of test that's evolving is mass spec, as you mentioned, mass spectrometry. So this is more of a different technique or chemistry technique to basically identify proteins that are separated by their mass to charge ratio, essentially. There are certain specialized centers offering the test, like the Mayo Clinic, for instance, offers mass spectrometry. And this actually has better sensitivity detecting very, very small monoclonal proteins beyond just a serum particle electrophoresis. And so there's been some early data, for instance, Ben Dermans did a nice study at University of Chicago showing that actually MRD by mass spec is actually pretty similar to MRD in the bone marrow, which is encouraging. And so I think, of course, we need more data with this. There needs to be more consensus on how we would actually evaluate for MRD by mass spec. But, this is a blood-based test. And potentially could be widely available in the future. And so I think that's something of the future that could be used as an adjunct to bone marrow MRD testing, imaging, and all the other testing that we already discussed.
Yeah, so we actually we had our webinar on MRD a few weeks ago, and we had Dr. Derman on that webinar, and he talked a lot about mass spectrometry. And Dr. Rafael Fonseca was also there. So the two proponents of MRD testing, and they talked a lot about those things. So again, if anybody's interested in learning more about that, we have a recording of that on our website as well to learn more about that. So.
And I want to mention one additional point. The nice thing about mass spec is that it's also able to distinguish between sort of your therapeutic monoclonal protein and your disease-related monoclonal protein. So as people may know, if you're on daratumumab or elotuzumab or any monoclonal antibody, that protein will actually show up at a very low level on your serum particle electrophoresis. But mass spec will be able to distinguish actually, between your monoclonal protein that you're actually receiving for treatment versus your own myeloma disease-related monoclonal protein.
So, Lauren, how often are you having these various tests like blood draws, bone marrow biopsy, and imaging? And what is it that you look for in these tests when you're discussing the results with your doctor?
So I get monthly blood work now, and always looking at my panel. I want to know what my lymphocytes and my white blood cells and my neutrophils are doing, so I can see how my immune system is
Right.
The status of what's going on. And of course the M spike, hoping that it's not going anywhere. And the light chains. Those are the main things that I look for. And, in my chart, it's really easy. You can see if something's out of the normal range.
Sure.
And if there's something that's popped out of normal, that's not. There's some things are consistently out of normal these days. But, if there's something new that I want to talk to the doctor about, then, that's a good way to really quickly get a look at things. Then there's the annual imaging, the PET scan, CT, or the MRI. For me, I don't do well in the MRI tube. So, I would hope for the PET CT that's just my personal preference. And then the annual bone marrow biopsy. And I am one of those people who doesn't mind so much the bone marrow biopsy. I wouldn't call it a bee sting. That might be a little bit extreme for me, but something in between maybe. So, with me and my MRD obsession, I would do it more often. But my doctor has told me, like you discussed, that it is just a needle in one spot and there's a lot more to it. So, I need to, try to change my thinking a little bit. And I will make a comment about the X-ray. It's interesting that here, X-ray is considered almost like the dark ages now. And my initial diagnosis was off an X-ray for a broken collarbone, and the orthopedic doctor knew instantly what it was from one look at the X-ray.
Yeah. He just saw a lot of lesions there.
It was just one giant lesion.
Just one giant lesion. Wow.
And 5 broken ribs. So there was plenty for him to view.
I guess. Wow.
And then the others said, no, that's not good enough. We don't believe him. You have to go and get all these other tests, and it was pretty definitive after all of that.
So at least you were, You hear many stories from patients who like go for months of testing and they just diagnosis just eludes them for a long, long time. And in the meantime, their myeloma is growing and they're getting organ damage and it can be really serious. The people have delayed diagnosis like that. So I always like to hear the stories where people are diagnosed like right away. That's
Well,
good.
I had a annual physical about 10 months before that all happened, before
Mhm.
breaking bones. And if I went back and looked at those labs and those early indicators were showing they were just out of range.
Really, they were there, but yeah,
It
but
was
nobody saw it.
And it
Mhm.
was kind of this like, oh, we'll watch and wait, or there was just no
Mhm.
reaction to it. And that's really unfortunate because I could have caught it much earlier.
Yeah, yeah. So
Hindsight.
yeah, it's a very common story though. Myeloma just isn't that it's just not that common, a cancer. And it's not always top of mind when patients go to the doctor and say, I've got this pain in my back or whatever. And, then doctors are like, well, you probably strained a muscle. Here, take this muscle relaxer. It's never diagnosis is just not easy with this disease because there's many symptoms that just could be symptomatic of other problems. So it can be hard to diagnose, especially if you're going to someone who's not a specialist, and doesn't really know anything about myeloma.
Especially
So
for younger patients. I mean, all the
sure.
pain, I
Mhm.
just thought I had just turned 50. I thought I was just getting old. I thought, God, this is 50. What's going to happen at 60? So
I know, right?
trade off to other things.
Yeah, right, right. Oh, okay. So, Becca, is there anything you tell patients in preparing for things like blood tests or bone marrow biopsy or imaging, and what should they anticipate with this testing?
So I think one of the most important things that patients might forget is collecting the 24-hour urine collection. We typically want a 24-hour urine collection after each cycle of therapy because it helps us to determine the level of bench Jones in the protein in the urine. And this is a big imposition for the patients because many times they have to have these urine jugs in advance, and it makes it very difficult to collect urine if you're out and about, right?
Yeah, right.
So I
Mhm.
would tell patients just grab a few extra jugs after their clinic appointment, just in case they don't forget the next time.
Mhm.
And, they should really discuss with their provider, appropriate time to turn in the urine because, your doctor, your nurse practitioners are going to work with you, right? I would also recommend for patients to try to get their blood tests in advance of their clinic appointment so that the
Mhm.
results can be made available. And
Mhm.
this makes the discussions a lot more meaningful.
Sure. Yeah.
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 And for
That
bone
makes
marrow
sense.
biopsies, just to remember to discuss anticoagulant hold times prior to the procedure, because there's many times when patients forget to hold their anticoagulants or this discussion never happens. It can cause a delay in the procedure and a delay
Mhm.
in treatment decision making.
Mhm. Mhm. Yeah, that makes sense. So, Dr. Lee, how does the frequency of testing, the blood test, the bone marrow biopsies, the imaging studies, does that change the frequency during various stages of disease? For example, when patients are undergoing treatment versus when they're in remission? And what about when a patient relapses?
Yeah, so when a patient's first diagnosed with myeloma, certainly we're going to check the blood work, at least the myeloma labs once a month with every cycle. So we want to know if the patient responding with a reduction in the paraprotein levels or the light chain levels with each subsequent cycle of treatment. And then in terms of the timing of imaging and a bone marrow, typically if a patient has a high volume of bone lesions or extramedullary disease, at baseline, certainly I wouldn't want to check that after induction therapy before the transplant if they're undergoing transplant with repeat PET scan. And then doing a bone marrow as well to assess response and also potential for MRD status. And then after a transplant, I would also repeat a bone marrow to also look for MRD status as well. Now, in the maintenance setting, I typically get surveillance imaging once a year at least. And so either this could either be a whole body MRI or a PET scan. I think we probably favor whole body MRIs just because of insurance approval challenges sometimes with getting too many PET scans, but
Right.
also
Mhm.
uh, MRIs can sometimes show sometimes very small subtle changes in the bones or bone marrow a little bit better than a PET scan. So there could be pros and cons of either test. Um, if for some reason a patient is what we call oligosecretory, so sometimes patients have either non-secretory oligosecretory myeloma, which means that they don't secrete much of the paraprotein at baseline, so that the blood work may not tell the whole story.
Right.
I'll probably do more frequent imaging, at least every 6 months, maybe even every 3 months, to monitor and track what's going on. And then in terms of the frequency of bone marrow, I think that probably like 7-8 years ago, I was doing bone marrows less frequently in the maintenance setting because it wouldn't really change management, to be quite honest. Because okay, if they're in complete remission or MRD negative, it's not really going to change things. But I think this is going to evolve over time. So I think there's a lot of ongoing studies looking at outcomes in patients potentially who discontinue maintenance early based on MRD status and seeing how those patients do. And those trials are actually ongoing. And so I think what's kind of made me shift a little bit to getting more frequent bone marrows, at least maybe every year for a lot of my patients on maintenance therapy who are MRD negative, is I do want to generate that data actually when the readouts do come out.
Sure.
Because I don't want to be like, oh yeah, this data just came out and it shows that if you have sustained MRD negativity for X number of years, it's just as good to just stop their maintenance. But then if we don't have that data, we can't act right away on that, if that makes sense, versus otherwise you have to generate that data prospectively from that time point. So I think getting, it doesn't necessarily have to be on the day annually bone marrow, but doing intermittent bone marrows and maintenance for MRD status, I think is good to get. And then, as I mentioned later on, when a patient relapses, getting a bone marrow at every subsequent relapse to see if there's been changes in genetics of the myeloma would also be something we would consider as well.
Yeah, right, definitely. Okay, so this has been a really productive discussion. I'd like to thank my my panelists, Dr. Lee and Becca Liu, and also our patient, Lauren Eves, for their contributions today. We did have a webinar on Learn Your Labs a few months ago. And as I mentioned, we also have a couple of pieces of information out there on MRD testing, both a webinar and a Facebook Live like this one. So those are out there on our website for anybody who'd like to look at those recordings and learn more about those things. I'd like to thank everybody who came online to watch us today. And finally, I'd like to thank our sponsors, Adaptive Biotechnologies, BMS, Cure, GSK, Janssen, Karyopharm, Regeneron, Sanofi, and Takeda Oncology. If you have any additional questions about what you heard today, please don't hesitate to call our MMRF Patient Navigation Center at 1-888-841-6673. Thank you. That ends our session, and I hope everybody has a great day.
Thank you.
Welcome.